An insurance crisis is coming, and your patients could be caught in the middle. We unpack how Trump's big, beautiful bill threatens coverage and what physicians need to know. So we talked to an old friend of the show, my brother, Adam Block. Adam is a PhD health economist who worked for Congress helping draft sections of the Affordable Care Act, and then for CMS writing some of the original regulations building the health insurance exchanges from there. He spent 5 years reporting to CFOs and data analytic roles, and then he founded Charm Economics, his health economics consulting company, and he's an associate professor of public health at New York Medical College. You're listening to Succeed in Medicine, the show for practicing physicians who want to master the parts of their career and life that med school never prepared us for. From interpersonal skills to career navigation to the essential information every physician needs. I'm Dr. Bradley Block, and in every episode, we bring you brass tacks advice and immediately applicable insights from world-class experts, so you can feel prepared wherever your MD takes you and build a life in medicine that's sustainable, rewarding, and actually worth all those years of sacrifice. Adam Block, welcome back to the podcast. It's great to have you again.
Great to be back, Brad.
I don't want to call it this more than once, just so everyone knows what we're talking about. We're going to talk about the big, beautiful bill. I don't think there could be a more Trump name for a bill, and I think both sides of the aisle would agree with that, than the big, beautiful bill. What is it, like HR 1, I think is what it's called?
I think that's the number. They all go by numbers. I will tell you, politically, Trump decided that he did not want to have a whole bunch of bills going on. He just wanted to do this one time rather than having a whole bunch of times where he has to help pressure and wrangle Congress, rather than what he did, which is like, I'm going to do this once.
Interesting move. Well, and it passed. So why is it such a big deal for the healthcare system? Give us like the quick summary.
So I think the biggest deal for the healthcare system is that there are going to be 10 plus million more people who are uninsured as a direct result of the bill. The methodologies are relatively complicated. It's through reductions in the ACA and reductions in Medicaid, which are not actually direct reductions. They're not just cutting people off. They're increasing paperwork burden and things like that. But the end result is going to be 10 million more people who don't have insurance. And at the end of the day, when you have hospitals with relatively low margins, that number is going to impact them.
If the listeners remember, we did an episode a few months ago before he took office on what we could expect from his administration. And this is one of the things that you talked about. It was the Medicaid work requirements was one of the things. And so, the Republicans say that Medicaid has been growing so rapidly and is so expensive that it can't continue to grow that way. And I think it would be hard to argue against that without, reforming the system in some ways. But they're seeking to reduce Medicaid expenses through what they call is eliminating fraud, waste, and abuse. So before we talk about how the bill works, isn't most fraud, waste, and abuse on the provider side with regards to Medicaid? Like, isn't it mostly people that claim to have given someone a wheelchair, but there was no wheelchair?
So I think that a lot of fraud, waste, and abuse comes from the provider side, or giving them a bunch of services, right? They could just say that we did this service that bills at $350 a service 100 times and then bill Medicare or Medicaid for that amount of money. They could file all the right paperwork for that, which is a lot faster and easier than doing the actual service. And then that's where most of the fraud comes from. It's from the provider side, who are actually actively billing Medicare for a whole bunch of services that they're doing. They can just tack on to it a whole bunch of other money. There is some fraud in terms of people entering into the Medicaid program, particularly the Medicaid program, that probably shouldn't be there. And there's a whole bunch of paperwork that you could sort of roundabouts that you can get into it, even if you probably shouldn't be into it, which is my way of saying, like, so the best example of that is that you could have someone that has a house worth $3 million that needs long-term care. And in New York State, you get provided long-term care if you're in the Medicaid program. So you just sign over the house to your kids and you sign over the money that you have into a trust, which is then technically not your money, but you have access to it. And then you can plead poverty, which is really not the way that you're supposed to do things. But there are tons and tons of elder care attorneys that will support you in doing this. and then you can enter into the Medicaid system.
So it happens on both sides, but currently most of it is happening on the provider side. But what they've chosen to go after is those circumstances like you're referring to, right? You need to be able to prove now that you really do, that you're in genuine need of Medicaid. And so how are they doing that?
Yeah. So the real way that they're doing that, the real direct approach, and they're not going after the folks who are wealthy that are doing the methodology that I just said, that there's no major changes to that I know about. And that's very state specific, meaning like you have to have states that actually cover long-term care in order for that to be an issue. The place that they're going after is what's called work requirements, which is basically the day-to-day Medicaid person. There are lots of people who have very low incomes, and those people who have low incomes, many of them, some of them have steady low incomes. A lot of them have what I would call lumpy incomes, where they cut grass in the summertime and shovel snow in the wintertime and don't have much to do in the springtime. And so what it's creating is work requirements for them, where they have to basically submit, on top of all of the other Medicaid requirements, they have to submit proof that they have been working for, I believe, 80 hours a month. There's a whole bunch of exceptions to that, but proof that they've been working. And the tricky part of that is A, doing it, and B, getting the appropriate paperwork, because you could be working as a babysitter in a variety of roles, selling fruit on the corner, and you don't have basically any proof, real proof that you're doing that. And so all of those folks in more shadowy markets, not necessarily the folks that are working at minimum wage jobs, but in different types of markets,
like cash markets, right? People that are typically paid cash.
Yeah. So not doing things that are illegal, but doing things that are more cash businesses. And there are a lot of cash businesses out there that wouldn't then have that paperwork in order to prove, they could prove their income is low, but they can't prove that both their income is low and that they have been working. And so those folks would be rolled off of Medicaid.
Okay. So right now there are 71 million people on Medicaid. And so a certain percentage of those need to show their work requirements, and they're going to have difficulty doing that because of their cash business. But there's also, I remember when the Affordable Care Act was rolled out and the computers shut down. So it's also possible that these work requirements are just not going to be something tenable that the administration is going to be able to contend with, right? You're going to submit your requirements and the computers crash. Like,
on a
is
path
that
to nowhere? Yes. So absolutely, that is, I don't want to say by design that it's intentional, but it's not like these work requirements, like they're getting submitted via paperwork. And like, there are lots of instances where the federal government is just way, way behind in terms of like doing their evaluations. The classic example of that is anyone that's applied for disability. When you apply for disability, you frequently get in a waiting list that is 18 months long. And for some people, many people, the disability is over by the time they actually get the disability payments, and they do start to get it. So it creates a huge cash problem for those people. And I think that aligns with your point, which is like, it's not like there's going to be a whole, this is all happening at the same time that HHS is shedding workers. And so it's not clear that the work requirements that get submitted are ever going to be reviewed. And if they get rejected for whatever grounds, it's unclear with you.
Yeah, that happened to us, where one of our kids needed surgery abroad and we submitted our paperwork to the insurance company and they were like, you didn't fill it out right. You had to do this. And we're like, we did. And then there was just radio silence for months. And then we had to reach out a bunch of times. So basically it was just not being processed properly by them. We did everything correctly. And if I'm correct, there are going to be multiple federal and state databases that are going to be cross-checking for this income and eligibility verification, right? Like Social Security and the Medicaid database and a number of other databases that government isn't really known to be the most efficient. Yeah. And so you're creating this backlog in order to get people off of them. And it sounds really like what the insurance companies do to us, right? Like, you need prior authorization. I've got a patient on a medication. They've been doing great for the last year. I need it renewed. And now I've got to fill out the same paperwork again that I did a year ago, even though nothing has changed. And the reason that they do that is they hope that a certain percentage of people just aren't going to do it. And then they don't have to spend as much.
Yeah, that is definitely one of the reasons that utilization management tools for insurance companies, which you would call prior authorization, step therapy, that sort of stuff, that is one of the ways that it is effective, is that people just give up with the paperwork. And usually the people that don't give up with the paperwork are people like you who are physicians who knows how the system works. And the people that do give up are people with don't speak English very well. They just say, you know what, forget it. I'm going to just do what I'm going to do and hope it works out, but I'm not going to do the paperwork the right way because I tried and we didn't succeed with it. They didn't do their part on their end. And there's nothing I could do about this.
Or I've got 3 kids and I've got 2 jobs and I'm struggling to make ends meet. And I got 4 hours of sleep last night and I'm struggling to do this paperwork that I don't understand. I've been trying and there's no one to help me. So I'm just not going to do it.
So the short answer to how Medicaid is going to fundamentally shift is that there is going to be an increase in the paperwork burden for Medicaid people who are enrolling. The other increase in the Medicaid burden, it is not going to just be the work requirements, but you're also going to have to re-enroll every month. There have been some changes where you were able to re-enroll less frequently, either semi-annually or annually, and you were just in for that period of time. Now you got to do it every month. And so people are just going to fall off because they're going to submit their paperwork late because they have complicated lives. Or as you said, sometimes it's going to be error on the side of the state or federal agencies that are, at this point, we've seen enormous numbers of layoffs at HHS. They're less well-funded. Well, but also at the IRS, at Social Security, at a lot of organizations that are involved in communicating directly with the public, we've seen a lot fewer employees. And so the lines for those, meaning like the lines for those are going to be longer.
Yeah.
I think there is a philosophy in the administration that sort of goes deep into this administration and goes back to the role of Elon Musk in it, that AI is going to be able to very, very, very inexpensively fill in those gaps. I think that is an open question that is left to be determined. I don't know that it is going to work. I don't know that it's not going to work. We see that the role of AI is expanding. And if you think about how it has changed in our daily lives in the last 5 years relative to now, I certainly wasn't using ChatGPT on a daily basis 5 years ago. I am using it on a daily basis now, and it solves a lot of problems for me a lot more quickly. And in 5 years, it's going to be able to do a lot more than it does now. That's in a very fast part of the growth curve. So it's possible that it is able to handle customer service. And the place that we see this in the insurance industry is that the insurance industry with prior authorizations is basically running the prior authorizations through AI technology. And a lot of the larger healthcare organizations that are submitting those prior authorizations are doing the same thing. So you basically have chatbots that are working against chatbots on the other side.
Yeah, that's really interesting. So that's a big assumption, right? AI will be able to fill in these gaps and communicate within these government organizations if more efficiently. That's a big if. That being said, there is some time for this to happen. I would say it's important to create this stuff and prove that it works before you go and do something like this. But, we've already talked about how that's part of the design.
I think that is the philosophy of the administration, that they are going to shed government workers and use AI as the alternative to that for a lot of consumer.
There's some time because these work requirements are not being rolled out until when?
After the midterms. So I think 2027.
Yeah. Okay. That's pretty short. So you got a year and a half for them to get AI up and running at the government level. Oh yeah. I'm not skeptical about that at all.
Feeling stuck in your medical career? You are not the only one, and you don't have to figure it out alone. I'm Dr. Michael Hirsch, and this is Better Physician Life, a new podcast about the messy middle of a career in medicine. We'll talk about those moments when the dream you worked so hard for doesn't quite feel like the dream anymore, and what it's like to find your way forward. Every Monday, we'll have an honest conversation about rediscovering meaning in your work, reshaping your life in medicine, and creating a life and career you don't need to escape from. Because you can love your life and your career again. And it starts right here. Follow Better Physician Life with Dr. Michael Hirsch wherever you listen to podcasts, and start your next chapter today. A proud member of the Doctor Podcast Network.
Okay, so aside from the Medicaid work requirement, there's also the Affordable Care Act, which I would imagine Trump has a bit of a vendetta against because of how Obama embarrassed him, like, was it 15 years ago at
the National Correspondents' Dinner? Yes.
Yeah. So
I
now,
mean, who knows the reason for it? I mean, it also was because his first thing that he came in his first term was he tried to overturn the Affordable Care Act and was unsuccessful in being able to do it. However, I wonder if he came in this term and made it a priority. It seems like he had the political support to be able to do it. He probably could have done it if he wanted to.
but a lot of people like it, but it is popular, right?
So the
Which makes it tough.
reason, the political calculus, I suspect, is that he could have done it politically, meaning he could have pushed the Senate and the House to do it, but there would have been a negative response from the public, and he didn't do it, and he didn't push for it for that reason. So the sort of compromise, not that it's really a compromise because he didn't eliminate it, was that he's dialing it back. And so a lot of the expansions that happened during COVID, where they reduced the total price of care, meaning the premiums to individuals receiving tax credits, as well as they expanded the number of weeks that you could enroll. And they also funded a whole bunch of marketing campaigns. So you won't see, I remember seeing marketing campaigns. You will not see as many marketing campaigns. You still may see some from the state that are funded by the state, but you won't see as many because they're less funded by the federal government. And those are all going to have impacts on the enrollment in the Affordable Care Act and the exchanges. The thing that will end up costing more is the folks that end up not enrolling tend to be the ones that are on the fence that got pushed over the top by extra subsidies or by extra outreach or by extra weeks of enrollment, tend to be the ones that are the healthiest. The ones who are like, I got diabetes and I got hypertension and I'm 61 years old and I'll go on to Medicare in 4 years. They're the ones that are damn sure to get their paperwork in on time. And so they are the sicker ones. And so they make the premiums more expensive. The younger, healthy ones tend to fall off. And so what's going to happen is the premiums are going to actually become more expensive.
And there's a couple of other reasons why they're going to become more expensive, right? The tax credits are going to expire under this bill, so that's going to make it less affordable. They've also shortened the enrollment period by a month. So they're doing it, they're making it harder to do. So if you forgot, now you've got 1 month fewer to enroll, and they're also eliminating the automatic plan renewals. So this set it and forget it, now I've got my insurance, I don't have to worry about this anymore because it automatically renews every year. Now they're eliminating that.
Yes.
So there's going to be a whole
You have
bunch
to
of
do it every year.
like
And I'll tell
fewer-
you, I do this for a living. Like I study health insurance for a living, and I forgot to re-enroll in my plan this year, but it automatically enrolls me. This is not for an exchange plan, so it's fine. The point being, if I just do this every day and I forgot it for us, then anybody can very easily forget it. And insurance companies, while they want to have customers, they sometimes don't always want everybody to re-enroll.
Yeah. So then you've got fewer people enrolling through the exchanges. You've got fewer people on Medicaid. And what we're talking about is a lot of hospitals rely on those patients, right? So some of those patients are going to be uninsured and still roll into the hospital. And now they're not going to be able to pay their bills. And so there's less ways for hospitals to get paid. They're also going to be sicker when they do it because they're going to try and wait more stuff out because they're not going to have health insurance. So that's going to make it even more expensive. And so you've got some hospitals that have a high payer mix of commercial insurance and some that are really dependent on Medicaid, right? The rural hospitals and children's hospitals, right? 40% of kids are on Medicaid. And so what's going to happen to these hospitals?
I mean, the hospitals are concerned, rightfully concerned. Hospitals, my experience, operate on a margin of like 1%, 2%, 3%. What that means is that if you are $1 billion hospital, you have a cushion of $10 million to $30 million to work with generally. And that means if your revenue goes down by $10 to $30 million, you have now lost money in the year. You can see they are not organizations that are operating on 40 or 50% margin, where if you drop their revenue by a couple of percentage points, they make less profit, but they don't know it. Like these are organizations that are operating relatively close to zero margin. And so, when you reduce the number of people who are insured, who are actually paying them, because the vast majority of people who are non-insured don't end up paying for hospital visits. Hospital visits are insanely expensive. When you go and you get admitted for a couple of days, it could be $40,000 or $50,000. And the folks who are uninsured are not folks that not only can pay $40,000 or $50,000 out of pocket, but like they can't pay that back in a lifetime, many of them. So they don't even try. They just throw out the bill because why even bother? Let collections chase them.
Well, and from the prior administration, it doesn't affect your credit score, right? Medical bills don't affect your credit score.
Right.
So there's really no negative impact on them of not paying.
I think that may be one of the things that's changing. They don't pay, but the point is that the hospitals, the providers don't get the dollars for it.
Yeah.
And so that's just less revenue. And the best example of like why this is important is if you look at the Medicaid expansion from the Affordable Care Act, what you saw immediately after the Affordable Care Act passed is all the blue states said, we're going to expand Medicaid. And all the red states said, we are not going to expand Medicaid. And you had like 26 states expanding it and 24 states not expanding it. And then what you saw over time was that a bunch of red states, the CEOs of hospitals in red states were like, whoa, wait, if we expand Medicaid, first, the federal government pays for it. And there's a whole bunch of patients that are now uninsured that would be insured. And so I would be getting, they did the calculations, I'm sure, and said, I could be getting $5 million more a year if our government just decided to expand Medicaid. And so you saw red state by red state by red state passing and expanding Medicaid. Oklahoma, Louisiana, North Dakota, like all these states that consistently vote for Republican candidates for president and beyond were electing to enter into the Medicaid expansion. And the reason that they did that was because while they may not have agreed with Obamacare, they still saw it as like an opportunity to increase their income from almost exclusively the federal government. So to me, that is evidence of just how important Medicaid is to hospitals in both red and blue states.
And so previously, wasn't there a cap, or rather there wasn't a cap on the amount that the federal government would pay for Medicaid within a state, right? They would match whatever the state wants to pay to fund Medicaid in their state. The federal government would match it. And then under this, now is there a cap on that?
So we're going to nerd out for a second. So there's a rate called FMAP, which is the amount that the federal government pays for Medicaid. In New York State, Massachusetts, California, a bunch of other what I would call wealthy states, it's 50-50. So the federal government pays 50% of Medicaid and the state government pays 50% of Medicaid. In poorer states, Mississippi, Alabama, the government pays closer to 75% and the state pays 25%. So just to be clear, it is not an even match in every state, and it is dependent on the overall average income. The Affordable Care Act always makes things more complicated, and in this area also made it more complicated. So they said for newly enrolled patients in the Affordable Care Act due to Medicaid expansion, those folks would be covered at a 90%. It actually gets more complicated than that, but we won't make it more. Those folks would be covered at a 90% matching rate. And so essentially for all of these states expanding, it was almost free to them for the new patients to be covered. So the shortcut is that the federal government matches. It varies by state. The richer states get less, but the new folks get a almost complete match. Meaning like the federal government pays for almost all of the new folks.
Is that changing with this bill?
Not to my knowledge.
Okay.
Picture this. You're sipping your favorite cocktail on a spacious balcony. The sun is melting into the sea and you just saw the green flash. Behind you, an even more spacious suite is waiting for you. You work hard. You deserve a little luxury. Whether you're planning your next voyage or dreaming of one, Luxury Cruising with Dr. Consolidates takes you there. From insider tips to the world's most elegant ships, join her as she explores the world in style. Search Luxury Cruising and subscribe. Your pampered adventure awaits.
I want to ask about something that's unrelated to the ACA or Medicaid that might affect some of our physicians if they happen to own a surgery center or an endoscopy center or something like that. Because previously, we did not have site-neutral payments. What we had was if you're in a hospital and you provide the same service, you get paid more than if you're in an ambulatory service. So let's step away from Medicaid and the ACA for a second, because I want to talk about something that might affect some of our colleagues that maybe they own an endoscopy center or a surgery center or something along those lines, because previously we didn't have site neutral payments, which means if you were in a hospital from the patient side and you had an MRI, it would cost you significantly more than if you got it at an outpatient imaging center, or had surgery at an ASC, it would be less than if you had surgery at a hospital. And the assumption is because the people having it done in a hospital are sicker and therefore there should be a higher payment. But in some situations, it's just a matter of convenience why you have something from one place to another. So now they're getting rid of those. This bill calls for site neutral payments, which means irrespective of where it's getting done, you're going to be paid the same. Now, I would assume that doesn't mean that us that owns ASCs are going to do great because they're going to be paying us more.
I agree with that assumption. I'll share with you my perspective. So research organizations have been recommending that site neutral payments were implemented for years, if not decades. Most research organizations think that it makes no sense to pay two different organizations different amounts to do the same service. They're like, that's not efficient for the economy. Patients should get, right? If it's the same service, Medicare should be paying the same amount to the same folks. Hospitals have a different perspective, and the hospital perspective is that, hey, we run a hospital. Our EDs run a loss. Our OBGYN departments run a loss. You got to give us some cover for the fact that all of these organizations run a loss, and we are the ones that have EDs that are open 24 hours a day to treat essentially whatever anybody would need. And so that is...
Yeah, we're not just doing it for profit. We're doing it as a public service.
As a public, right, exactly,
yeah.
As a public service. And so these hospitals are effectively definitely doing this. And lots of people go to EDs and they feel a level of comfort, the fact that they can go to an ED 24 hours a day and get almost any service that they would need. And so the dollars for that essentially are being cross-subsidized through not site neutral payments, right? And site neutral payments gets rid of this advantage that hospitals have. And so you can see the argument on both sides for it, right? One is you're doing the same thing. And the other is, well, hospitals are providing this like extra level of care that you can go to. And if something goes wrong in an ASC, where do you go? Something goes really wrong. Something goes minorly wrong, you handle it. Something goes really wrong, you send them to the hospital that you are basically saying that doesn't need the dollars for this, when really they do, to make sure that there is a safety net, like a clinical safety net, to make sure that any major problem gets handled. So that's the fundamental thing that's happening. However, what I expect to be happening from a payment perspective is that the dollars are going to funnel away from these hospitals that have been receiving these payments in perpetuity for a very long time. I think this is going to be primarily one directional. Now, you may see a little bit of additional volume, but even that I wouldn't expect to be a fundamental change, because at the end of the day, patients aren't really seeing this, because it's the insurers that are paying all or virtually all of these fees.
Are there other ways that hospitals get subsidized for all of these care that they take of, the sicker populations and people that aren't necessarily going to be able to pay, right? It's not just through the lack of
yes.
But there are other ways, right? What are those?
Hospitals are a compendium of ways to do this. I mean, there's graduate medical education and indirect medical education. There are payments that go to hospitals for having too high of a share of Medicare and Medicaid government enrollees. So there's a variety of payments that go to hospitals. This isn't the only one, but the sort of justification for why there's this fundamental differential in payment comes from the fact that hospitals are providing this 24-hour opportunity for service, and lots of the other organizations that are providing these services, if something goes very, very wrong with the service, they're going to end up at a hospital's doorstep. But that happens rarely. But hospitals have to be prepared for it all the time, in the same way that firefighters have to be on call all the time. But it's not like they're fighting fires 12 hours out of a 12-hour shift. They're fighting fires a small percentage of the time, but they have to be able to deploy and fight them essentially all the time.
So it looks like our time has come to a close. So I just want to ask, from a political perspective, is it possible that this bill gets repealed before it starts getting enacted, right? Like, would it be politically,
I don't think so.
What would need to happen
I don't
for
think
that
so.
to happen?
So there's no real scenario, because Trump would veto a repeal anyway, right? So if the House flips, that blocks the Trump administration's ability to pass any major legislation, which is why Trump pushed so hard in the first part of the term to make sure that a lot of legislative priorities were passed basically immediately. Because with a 3-vote or 4-vote majority, it's not guaranteed that the House stays Republican in the second portion of the term. But you can't pass any passing legislation is very hard. You have to have the House, the Senate, and the presidency basically all together, because it's pretty rare these days that there is bipartisan bills that are passed. So I think the likelihood of this going away is extraordinarily unlikely.
On that note, and then it's going to happen after the midterm. So the people that are currently receiving misinformation about it aren't going to feel the effects of it in their lives until after they vote in the midterms. And this was also by design. So we have a lot to look forward to. Thank you for this. This has been very enlightening.
I'm always a lot of fun.
And talking politics and health policy is always a hoot. And once again, thank you so much for your time.
All right. Always a pleasure, Brad.
Thanks for listening. I have a favor to ask. You listened to the episode until the end, which means either you fell asleep or you really liked the episode. So please write us a 5-star review, take a screenshot, and email it to me so I can send you a quick guide on how to earn patient trust in 20 seconds or less. Email me at brad@physiciansguidetodoctoring.com and feel free to suggest a topic or guest. I take your requests seriously. The views expressed on this episode are those of the interviewer and the interviewee and do not represent the views of their employer or even their significant other. Even though the magic of podcasting makes it sound like I'm talking directly to you, this is not a doctor-patient relationship, and this is not medical advice, or financial advice, or legal advice, or really any advice. Thanks again for listening to Succeed in Medicine.